Welcome to Pediatric Case Review. Today, we are presenting a comprehensive clinical review on bronchopulmonary dysplasia. We will cover the pathophysiology, diagnosis, and management of this condition through 14 case-based questions. Let us dive into the presentation to enhance your clinical understanding. Question 1. Pathophysiology. A 24-week gestation extreme premature infant is now 4 weeks old. The infant required prolonged mechanical ventilation and supplemental oxygen since birth due to severe respiratory distress syndrome. What is the primary histopathological mechanism characterizing the new bronchopulmonary dysplasia in this infant? Option A, severe airway injury. Option B, arrest of alveolarization. Option C, primary surfactant deficiency. Option D, congenital pulmonary hypoplasia. The correct answer is option B, arrest of alveolarization and vascular development. Unlike the old bronchopulmonary dysplasia, which was characterized by airway injury and fibrosis from severe barotrauma, the new form is primarily due to extreme prematurity interrupting normal lung development. This results in fewer and larger alveoli, along with decreased pulmonary vascular growth. Question 2. Clinical presentation. An infant born at 26 weeks gestation is now 2 months old. The neonatology team is evaluating the respiratory status to determine the trajectory of the lung disease. Which of the following is the most common clinical manifestation indicating established bronchopulmonary dysplasia in this infant? Option A, central apnea. Option B, feeding intolerance. Option C, tachypnea and retractions. Option D, inspiratory stridor. The correct answer is option C, tachypnea, retractions, and prolonged oxygen requirement. The hallmarks of established bronchopulmonary dysplasia include persistent respiratory distress, increased work of breathing such as subcostal retractions, and the inability to wean off supplemental oxygen or non-invasive respiratory support like continuous positive airway pressure. Question 3. Examination findings. A 4-month-old former 25-week premature infant with known severe bronchopulmonary dysplasia presents to the Pediatric Pulmonology Clinic. The infant is on 0.5 liters per minute nasal cannula oxygen. Upon careful lung auscultation, which finding is most characteristically associated with bronchopulmonary dysplasia? Option A, diffuse fine crackles. Option B, absent breath sounds. Option C, harsh stridor. Option D, late squeaks. The correct answer is option A, diffuse fine crackles and expiratory wheezing. Crackles or rales indicate interstitial fluid or atelectasis, which are very common in bronchopulmonary dysplasia. Expiratory wheezing reflects airway hyperreactivity and small airway obstruction. You might also notice a barreled chest due to hyperinflation and signs of poor lung compliance. Question 4. Diagnostic criteria. An infant born at 27 weeks gestation is currently in the neonatal intensive care unit. The medical team is calculating the post-menstrual age to officially diagnose and grade the severity of bronchopulmonary dysplasia. According to the standard criteria, what is the fundamental requirement for the diagnosis? Option A, oxygen for over 14 days. Option B, abnormal chest radiograph. Option C, mechanical ventilation. Option D, oxygen for 28 days. The correct answer is option D, requirement of supplemental oxygen for greater than or equal to 28 days. The base criterion for diagnosing bronchopulmonary dysplasia is treatment with greater than 21% oxygen for at least 28 days. Severity is then evaluated at 36 weeks post-menstrual age based on the level of respiratory support needed. Question 5. Investigations. A 2-month-old infant with established bronchopulmonary dysplasia has an acute worsening of respiratory distress. To rule out pneumonia or other acute pathology, a chest radiograph is ordered. What are the classic radiographic findings of established severe bronchopulmonary dysplasia on a chest X-ray? Option A, ground glass opacities. Option B, hyperinflation with reticular opacities. Option C, lobar consolidation. Option D, massive pleural effusions. The correct answer is option B, hyperinflation with coarse reticular opacities and cystic changes. A chest X-ray in severe bronchopulmonary dysplasia typically shows flattened diaphragms from hyperinflation due to air trapping. You will also see coarse strand-like opacities representing fibrosis and cystic changes giving a sponge-like appearance. Question 6. Treatment and nutrition. You are adjusting the parenteral and enteral nutrition plan for a 1-month-old infant with severe bronchopulmonary dysplasia. The infant has poor weight gain despite standard newborn caloric intake. What is the recommended daily caloric intake to promote somatic growth and lung repair in these infants? Option A, 90 to 100. Option B, 100 to 110. Option C, 120 to 150. Option D, greater than 180. The correct answer is option C, 120 to 150 kilocalories per kilogram per day. Infants with bronchopulmonary dysplasia expend significantly more energy just to breathe. To promote alveolar regeneration and somatic growth while adhering to strict fluid restrictions, we must heavily utilize high-calorie formulas or concentrated fortifiers. Question 7. Treatment and diuretics. An infant with bronchopulmonary dysplasia requires long-term diuretic therapy to manage chronic pulmonary edema and improve lung compliance. The physician wishes to avoid nephrocalcinosis and severe osteopenia. Which diuretic combination is generally preferred for long-term use due to its calcium-sparing effect? Option A, chlorothiazide and spironolactone. Option B, furosemide alone. Option C, bumetanide. Option D, acetazolamide. The correct answer is option A, chlorothiazide and spironolactone. This combination is used for chronic maintenance because thiazides decrease calcium excretion, thereby reducing the risk of nephrocalcinosis and metabolic bone disease. Spironolactone is added to prevent hypokalemia. Chronic loop diuretics like furosemide cause hypercalciuria and should be avoided for long-term use. Question 8. Treatment and steroids. A 25-week premature infant is now 3 weeks old and remains on maximal ventilator settings. Multiple attempts at extubation have failed due to severe evolving airway inflammation and edema. Which medication is most proven to facilitate extubation in this severe scenario, despite its neurodevelopmental risks? Option A, inhaled budesonide. Option B, intravenous hydrocortisone. Option C, oral prednisolone. Option D, systemic dexamethasone. The correct answer is option D, systemic dexamethasone. Systemic dexamethasone is highly effective at reducing pulmonary inflammation and facilitating successful extubation. However, it is used strictly as a last resort because it carries a known risk of increasing the incidence of cerebral palsy and impaired neurodevelopment in premature infants. Question 9. Complications. A severe bronchopulmonary dysplasia infant develops episodic cyanotic spells, hepatomegaly, and a loud single-second heart sound on cardiac auscultation. Pulmonary arterial hypertension is highly suspected. What is the most appropriate initial non-invasive screening investigation for this complication? Option A, ventilation perfusion scan. Option B, transthoracic echocardiogram. Option C, right heart catheterization. Option D, high-resolution chest computed tomography. The correct answer is option B, transthoracic echocardiogram. Chronic hypoxia in bronchopulmonary dysplasia leads to pulmonary vasoconstriction and eventually right heart failure, known as COR pulmonale. An echocardiogram is the gold standard screening tool to estimate right ventricular pressures and identify right ventricular hypertrophy. Right heart catheterization is definitive but invasive. Question 10. Neurodevelopmental complications. A 2-year-old former 24-week gestation infant with a history of severe bronchopulmonary dysplasia returns to the high-risk infant follow-up clinic. The parents express concerns about the child's motor and language milestones. Infants with severe bronchopulmonary dysplasia have the highest associated risk for which long-term outcomes? Option A, autism. Option B, neural tube defects. Option C, cerebral palsy. Option D, hearing loss. The correct answer is option C, cerebral palsy and cognitive delays. Severe bronchopulmonary dysplasia is an independent risk factor for poor neurodevelopmental outcomes. Factors like chronic intermittent hypoxia, prolonged mechanical ventilation, recurrent infections, and postnatal steroids cumulatively injure the developing brain, making early intervention services absolutely mandatory. Question 11. Growth associations. A 6-month-old infant with bronchopulmonary dysplasia is noted to be falling off their growth curve. The infant is formula-fed and has no significant emesis or diarrhea. What is the primary pathophysiological reason for growth failure in infants with established bronchopulmonary dysplasia? Option A, increased resting energy expenditure. Option B, intestinal malabsorption. Option C, hypothyroidism. Option D, feeding aversion. The correct answer is option A, increased resting energy expenditure. Infants with bronchopulmonary dysplasia have poor lung compliance and high airway resistance. This drastically increases the work of breathing, which raises their resting energy expenditure by up to 50% compared to healthy infants, leading to a massive demand for calories. Question 12. Infection associations. An ex-premature infant with bronchopulmonary dysplasia is being discharged home in November. The pulmonologist emphasizes the extreme risk of severe respiratory failure if the infant contracts a viral illness. Which prophylactic intervention is standard of care to prevent severe disease from respiratory syncytial virus in this population? Option A, inhaled ribavirin. Option B, prophylactic oseltamivir. Option C, hyperimmune globulin. Option D, monthly intramuscular palivizumab. The correct answer is option D, monthly intramuscular palivizumab. Palivizumab is a humanized monoclonal antibody directed against the respiratory syncytial virus fusion protein. It is given as a monthly intramuscular injection of 15 milligrams per kilogram during the viral season and is strongly indicated for infants with bronchopulmonary dysplasia on medical therapy. Question 13. Oxygen target management. An infant with severe bronchopulmonary dysplasia is being prepared for discharge on home oxygen therapy. The parents are being trained on using the pulse oximeter. What is the generally recommended target oxygen saturation range to balance oxygen toxicity risks against the prevention of COR pulmonale? Option A, 88 to 91%. Option B, 92 to 95%. Option C, 96 to 100%. Option D, greater than 98%. The correct answer is option B, 92 to 95%. This is the sweet spot for established bronchopulmonary dysplasia. Maintaining saturations lower than 92% exacerbates pulmonary vasoconstriction and impairs growth. However, targeting saturations higher than 95% generates reactive oxygen species, which contributes to ongoing lung injury and oxidative stress. Question 14. Prevention. A pregnant patient at 24 weeks gestation presents with preterm premature rupture of membranes and signs of imminent delivery. The obstetrician consults neonatology. Which antenatal intervention is most proven to accelerate fetal lung maturation and reduce the severity of respiratory distress syndrome and subsequent bronchopulmonary dysplasia? Option A, antibiotics. Option B, magnesium sulfate. Option C, antenatal corticosteroids. Option D, postnatal surfactant. The correct answer is option C, antenatal corticosteroids. Administering antenatal steroids like betamethasone accelerates pneumocyte development and surfactant production. This primary prevention strategy significantly reduces the incidence and severity of respiratory distress syndrome, intraventricular hemorrhage, necrotizing enterocolitis, and overall neonatal mortality. Welcome to our Patreon community, Pediatric Case Review. This community contains all videos perfectly arranged by system, so you can easily access everything in one place. All presentations used in our videos are also available as high-quality photos, so you can read and practice all questions at your own pace. For details and how to subscribe, please comment below in this post, and we will message you. In conclusion, bronchopulmonary dysplasia requires meticulous, multidisciplinary care. We hope this comprehensive review has enhanced your clinical understanding. Please follow our Pediatric Case Review channel for more informative presentations. If you have any questions or need further clarification, drop a comment below. Thank you for watching, and we will see you in the next video.